Welcome to another session of the hearing education series. My name is Jack Wazen. I'm the Director of Otology and Neurotology and of the Cochlear Implant Program at Sarasota Memorial Hospital, and the VP and Director of Research at the Ear Research Foundation. And today we're going to talk about hearing loss in the brain, cognitive function, dementia, etc. So, advancing. So, a famous author, Helen Keller, had said in her writings, deafness separates people from people. Helen Keller was deaf and blind, and she described as blindness separating people from things, but deafness separates people from people. And all of us who have worked with or witnessed hearing loss and deafness fully understand where this statement comes from. So let's talk a little bit about our ear anatomy here. You know, the hearing system is one of the oldest systems to develop in the embryo. And as the baby is forming, the hearing is developing. By the time the baby is born, the hearing system is completely developed. It is a crucial function for survival. I mean, initially, before people were people, the hearing system was to help animals and people in the animal world to recognize what's around them. So it's crucial in the survival instinct of all animals. It helps you identify danger and risks. And it also affects language and communication skills, learning skills, emotions. So can you see the whole picture there, or is this screen covering it? Do they see the whole thing? So the ear is made out of three parts. I'm going to move this thing. Could you move this thing away from me, from the slide?
Just a little.
Little one?
Yeah.
Okay. So here's the ear, outer ear until the eardrum here, middle ear system, inner ear system, and then you have the nerve that connects the cochlea and the balance part, the vestibular, to the brain. And here you see how those nerves are going to enter the brainstem and climb up to the auditory cortex. The auditory cortex is in the temporal lobe, which is right here on the side of the brain. And this is where information that is picked up by the ear is being interpreted and centralized at the brain level. All of these are important factors in the hearing and the interpretation and the understanding of speech. So within the brain, temporal lobe right here, frontal lobe is in the front. The temporal lobe is where the primary auditory cortex is. This is where hearing is supposed to be interpreted at the brain level. We're going to talk a little bit more about the frontal lobe in a bit, but the frontal lobe is the biggest lobe in humans because this is where the sense, the thinking and the analysis and all of that human advancement of brain function is occurring in the frontal lobe. The ear and the nerve and the lobes are all tuned like a piano is tuned. So in the ear, the basal turn of the cochlea, which is the base of this snail, the basal turn is related to the high pitches, the high frequencies, and as you go into the lower frequencies, it is more towards the tip of that snail. So if we damage this section here, we are damaging high frequencies. If we damage this section here, we're damaging low frequencies. Same goes through here in the auditory cortex, also tuned like a piano. Different spots respond to different frequencies. Some population statistics, and you could read that, but basically the summary of the slide is that the older population is growing significantly. And even though the total population in the United States, the population growth is slowing down, the percentages of older people is going up. So US population 85 and older grew 30-fold in the same time frame that people under 65 grew. They grew 3-fold. And that's between 1900 and 2000. So big differentiation in the age of the population. And you could see that also in that curve, increase in the older population. Florida has the highest proportion of older people, 16.7%, although numerically California has the largest number of older people, followed by Florida and then New York. So we have a lot of older people amongst us, we being part of them. And what happens as we get older is that we get age-related hearing loss. It's called presbycusis. So the hearing is starting to slow down. We're going to lose the high frequencies first. And as we get older, the middle frequencies will go down, and then, of course, the low frequencies. So what happens when we start losing hearing? It causes strains on relationships. And I hear it every day in my patients. Spouses are very frustrated with the other spouse, not listening, not hearing, not paying attention. It causes social isolation. So as the hearing loss becomes more significant, people do not want to socialize anymore. They don't want to go to restaurants. They don't want to visit people because they are embarrassed about not hearing or understanding what is being said. And then eventually it leads to depression. So all of that is a progressive outcome of progressive hearing loss. Numerous studies have confirmed a relationship between hearing loss and cognitive decline and dementia with aging. So a few years ago, the National Academies of Science, Engineering, and Medicine ran a meeting, a study forum on hearing healthcare in adults, because they recognized that an estimated 30 million people in the United States have hearing loss. And hearing loss has been identified as the 5th leading cause globally of years lived with a disability. Furthermore, as the US population of older adults increases, hearing loss will become an area of greater concern. It's a vital human sense that can be important to communication, health, and affects quality of life. Yet, for a variety of reasons, many people with hearing loss do not seek out or receive hearing health care. Why? Estimates of hearing aid use are that 67 to 86% of adults 50 years and older who may benefit from hearing aids do not use them, and many hearing assistive technologies, as well as auditory rehabilitation technologies, are not fully utilized. So in that meeting of the Academy of Sciences, they said, long seen as a issue for individuals, And to some extent, families and friends, there's a growing recognition that hearing loss has a significant public health concern that can be addressed by actions at multiple levels. So they have a set of guidelines recommending key institutional, technological, and regulatory changes that would enable consumers to find and fully use the appropriate, affordable, and high-quality services, technologies, and supports their needs. So here's the reality. Why do people not use hearing aids? Well, they're expensive. Yes, we know they're expensive. But believe it or not, even in countries where hearing aids are covered by the government or by insurance, it is the same problem as we have here. Same percentages of people not using hearing aids in countries where they offer it for free as it is in our country here, where people have to pay for them. So cost is not the only issue. Vanity, that's a big issue. Denial, that's a big issue. People don't want to be seen wearing a hearing aid because they feel embarrassed that they're wearing a hearing aid. Well, guess what? I say hearing loss is more noticeable than a hearing aid. If you're having a hearing loss and you can't fake it, you can't deny it, because it's obvious to everybody around you that you're missing things. But if you're wearing a hearing aid, particularly the newer ones that are barely visible, then you're normalized and people are not picking at you and people are not criticizing you. And you don't look like you have a hearing loss because you hear. So in order to fix this cost thing, the FDA recently, over the last year or two, approved the over-the-counter hearing aids. Over-the-counter hearing aids are hearing aids that are not customized to your audiogram, to your hearing thresholds. They're like mini amplifiers. You put them on, you turn them on, and that's it. They are recognized for people who have mild to moderate hearing loss. Most of these people don't use hearing aids anyway. If you have mild to moderate hearing loss, the over-the-counter can be of help. If you have moderate to severe hearing loss, they're not good enough, and you will be disappointed in using them. You really need a more customized and programmed hearing aid that fits like a glove to your audiogram. In a publication in the Lancet, Lancet is a British medical journal. It's one of their top journals. They looked at potentially modifiable risk factors for dementia. And their conclusion, they ran a study in 2017 and another one in 2020. And their conclusion, both times, is that hearing loss in the mid and late life was identified as the single largest potentially modifiable risk factor for dementia. Is it going to cure dementia? No. Is it causing dementia? No. But if you are developing dementia, if you are genetically predisposed to that, to have cognitive decline, Alzheimer, or other kinds of dementia, the better you hear and the better you communicate and the better you are in contact with your world, the less decline you will suffer. So we want to make sure that as your hearing declines, we fix that problem to give you all the brain benefits that hearing will give you. So why is it that hearing can cause cognitive decline or is associated with cognitive decline. There are three theories. One theory is called the common cause hypothesis, which says as your brain is aging and deteriorating, your hearing system is deteriorating, and your frontal lobe, your cognitive center, is deteriorating at the same time, and you're having widespread neural degeneration. Well, that's one of the mechanisms. The other theory is called the degradation hypothesis, which means poor auditory performance compromises cognitive function by reducing the information available for processing. So you need some information to understand, to think, to discuss, and that information comes from the auditory system. And if you don't have that, it affects cognitive function. And the third theory is called the cognitive load hypothesis. What this means is that if you are having hearing loss, you are using your frontal lobe to help you understand what you hear. So the temporal lobe, which is where hearing is supposed to be happening, is not doing the job. So now you are hearing things, you don't understand what they are. Now your frontal lobe is trying to fill in the blanks by guessing based on what the word sounds like or what the sentence sounds like. And as the frontal lobe is now being busy interpreting hearing and sound, it is losing energy in what it is supposed to be doing, like memory and other thoughtful activities. A study of MRIs called functional MRIs. Functional MRI is an MRI that shows the picture light up of which part of the brain is being stimulated. So in a normal person, when you stimulate hearing, the temporal lobe lights up on the MRI. You get the picture, the temporal lobe is lit. That's normal. In people who have hearing loss, the frontal lobe is lighting up. It's not supposed to, but why is it lighting up? It's because you're using thinking from the frontal lobe to understand the words that you're missing. So that creates an overtaxing of the activities of the frontal lobe, which is leading to more and more cognitive decline. So this graph is again showing how hearing loss affecting brain structure and function and leading to cognitive impairment and dementia. Along the way, we have the cognitive load theory, and we have social isolation, and we have the degenerative processes for both the brain and the hearing system. Effortful listening, that's a word that is used. If you're listening through your normal hearing system, it is effortless. If you're listening and putting some thought into it, it's effortful, and it creates a declining function of the frontal lobe. So these are a few articles. I don't want to bore you with them, but there's a lot of literature here showing all of what happens as we age with hearing loss. This study here from Hopkins, and it's a longitudinal study, which means it continues to follow people over time. This study confirms that hearing loss is independently associated with accelerated cognitive decline. So hearing loss, social isolation, loneliness, cognitive load, an intact auditory system and proper cognition function of the brain are essential for language communication skills. Deprivation of auditory input leads to reorganization of the topographic map of the auditory cortex. That's a very important statement here. Let me explain it. So we said that the temporal lobe is the center for hearing. If any part of the brain that is not being stimulated goes lazy, shuts down. So if you are not sending hearing to the temporal lobe says, I'm not getting any stimulation here, but the neighboring structures of the temporal lobe, which is the visual cortex and the proprioception cortex. The visual cortex is the eyes, and the proprioception is your sensation of touch and feel along your body. Those are next door to the auditory cortex. So when the auditory cortex is not receiving stimulation, the ocular visual cortex moves in, takes over. The proprioceptive moves in, takes over. So now that landscape in the brain that was dedicated to hearing is being occupied by visual and proprioceptive. Now, 5 years later, 10 years later, you say, okay, now I got it. I need hearing aids. It's too late, because now you're sending the information to the brain, but the brain is lacking the nerve brain center to interpret that information. That's why it is crucial that we do not neglect and we do not procrastinate on hearing stimulation, so that you do not lose the opportunity to maintain that system. When we do cochlear implants with people who have profound hearing loss, the best results in cochlear implants are for people who have had their hearing loss for less than 10 years. The older your brain is deprived, the less results we're going to get. It's not always the rules. We've implanted people who were deaf for 20 years and 30 years and who are doing well. But if we wanted to predict, if we wanted statistics, you're better off getting hearing restoration, either with hearing aids or with cochlear implants, if hearing aids are not enough, to restore hearing and to reduce the cognitive load on your brain. Here's another longitudinal study. Hearing loss, independent predictor of developing dementia. You don't want to risk it. If you have hearing loss, fix it. Hearing aid use was associated with better cognition. So if we're having a person who is getting cognitively declined, we want to make sure that we stimulate their hearing and their brain function with better hearing. That helps preserve cognition and prevent a rapid decline in cognition. Cognition is significantly poorer in individuals with untreated hearing loss. The degree of cognitive deficit is significantly associated with the degree of hearing loss in both treated and untreated individuals. So I think you're getting the message. Hearing loss is a serious condition. It affects quality of life. It affects social interactions, motor skills, psychological aspects. And there have been studies that show that people who have hearing loss are more likely to fall. So your balance could be affected also when you're suffering hearing loss. Long-term hearing deprivation can impact cognitive performance by decreasing the quality of communication, leading to isolation, depression, and dementia. And in conclusion, effective intervention with hearing aids or cochlear implants may improve the social and emotional function, the communication skills, the cognitive function, and quality of life. Actually, we are running a study on cochlear implants and cognitive changes. And we are testing people cognitively. We do cognitive testing on patients who are candidates for cochlear implants. So we test them before an implant is placed to measure their cognitive status, and then we measure their cognitive status after implantation at 1 year and 2 years after implantation. And the reason we wanted to do that is to see, is there a cognitive level before we implant that says this person is too far out cognitively that he's not going to benefit from an implant? And the other question is, will placement of a cochlear implant delay the cognitive decline over time? So this is the test. It's called the SAGE test, S-A-G-E, self-administered girocognitive exam. So we're under that test in our office under supervision because we don't want people to cheat. Because people ask their friends and look up answers and so on. So we don't want that. And we found that cognitive decline has a relationship with the response to a cochlear implant. People who have significant decline don't do as well with a cochlear implant. So the use of that test could be used to predict speech outcomes after cochlear implantation in older adults. And we use it to test and screen people for mild cognitive delay or dementia before receiving the implants. So we use it as preoperative counseling, and now we continue longitudinally, like the Hopkins study, to see what is the rate of decline after cochlear implantation compared to people who have not been implanted. So here we are. I think I will leave some room for questions now, because some of your questions may bring up some of the items that I wanted to focus on. So do I have any questions, Christina?
No questions have been submitted yet.
If you guys have any questions, you could submit it on your screen. I think we have summarized the risks of hearing loss. It's not just that your spouse is nagging you. We need to make sure that you continue to communicate. We need to make sure that you continue to stimulate your brain with auditory information. Now, how do we do that? There's a huge range of ways to do it. We talked about the over-the-counter hearing aids. That's for mild to moderate hearing loss. We talked about regular hearing aids. and there's a bunch of them. They have to be programmed exactly to your audiogram shape. You cannot just get them programmed on the computer. Then the next level up is called an ear lens device. The ear lens is a very smart hearing device, and we will be having another session purely on ear lens in the near future. So keep your eyes open. You'll see it, sent to you, invited to attend that. But basically, with the ear lens, there's like a contact lens that sits on your eardrum, and that contact lens is receiving electromagnetic stimulation from the processor. If you put that processor without the lens on your eardrum, you don't hear anything because there's no sound. There's no speaker in that thing. It drives the ear and the inner ear in a much stronger fashion and a wider speech frequencies. It gives you more low frequencies and more high frequencies than the hearing aids can do. And that gives you a richer and better hearing. So over-the-counter, regular hearing aid, ear lens, cochlear implants. So cochlear implants are for people whose hearing loss has dropped significantly enough that hearing aids or ear lens is not the answer anymore. That's when we go for cochlear implants. So there's a huge range. Nobody should be walking around hearing impaired or deaf unless they want to. We have questions coming? Okay.
What about the benefits of hearing aids if your hearing loss is not severe enough for cochlear implants?
So the benefits of hearing aids, if the hearing loss is not significant enough for a cochlear implant. So as I was just saying, in regular hearing aids, they could have different powers that you could increase the power of the hearing aid. But if you have maximized on the power of the hearing aid and you're not a cochlear implant candidate yet, I think you ought to consider the ear lens system, because that could be a happy medium in between hearing aids and cochlear implant.
And then another question that goes with that is, what are the best hearing aids for moderate to severe hearing loss?
For moderate to severe hearing, there's no best hearing aid. A lot of companies do great hearing aids. Big names, Resound, Phonak, Widex, Oticon. These are all major hearing aid companies that you cannot go wrong with.
Next question is, where does tinnitus come into this loss?
Oh, tinnitus. Good question. As your hearing system declines, then those cells of hearing that are supposed to transmit those frequencies to the brain, as these cells degenerate, they become transmitting these same frequencies without being stimulated from outside sounds. So this is an internal sound that is generated by damaged hair cell or nerve cells in the inner ear and all along the brain. That's what tinnitus is. Now, when we see somebody who says, I have tinnitus, we need to investigate and see, why do they have tinnitus? Do they have tinnitus because it's natural progressive loss of hearing and tinnitus, garden variety tinnitus, or do they have tinnitus because there is a condition of the ear, a disease of the ear that is causing that? So if it's bilateral, equal, both sides are the same, no other symptoms, it is safe to assume that it is benign garden variety tinnitus. But if it's only on one side, or if it's pulsatile, meaning it pulsates, then there's a reason for it. So we have to do the appropriate testing to diagnose the cause of the tinnitus, to see whether it is linked to the hearing loss. We need to rule out that tinnitus is not due to inner ear disease, brain tumors, acoustic neuromas, things like that need to be ruled out before we say go and live with it. And by the way, we don't say go and live with it. We tell you how to live with it. Because although there is no permanent cure for tinnitus, fighting sound with sound is the most effective way to mask the tinnitus. Masking is very efficient with tinnitus. How do you mask it? You want to bring in the external sounds that the inner ear is not receiving, so the brain is only listening to its internal sounds. So we mask the tinnitus. And for somebody who has the combination of hearing loss and tinnitus, hearing aids play a big role.
The next question is, how does hyperacusis operate here? I stopped using my CI because it only added to the noise.
Hyperacusis is a very, very difficult and frustrating thing to treat. We treat hyperacusis typically by reducing the sound that is reaching the ear. But hyperacusis is not just an ear issue. Hyperacusis is a central nervous system issue. It's how the brain, the central auditory cortex is responding to sound. So by decreasing the noise level coming into the brain, we could reduce hyperacusis, but sometimes it's not enough. And if you are having significant deafness and hyperacusis, that's a difficult situation to be in. I don't know that there is even if we take out all of your ear and cut off the nerve, you'll still have hyperacusis. It's coming in from inside. It's central.
So the next question is, if someone has hyperacusis, will that person also experience or observe hearing loss or decline?
So the question is, if somebody has hyperacusis,
Will they experience or observe hearing loss or decline?
will they observe hearing loss or decline? Not always. You could have hyperacusis and your hearing could be perfectly fine and normal. Or you could have hyperacusis and have a mild hearing loss or a moderate hearing loss. So it could go either way. But having hyperacusis does not necessarily mean that you're going to lose your hearing.
Are there any treatment options for hyperacusis or management techniques?
There are management techniques for hyperacusis, yes. And the management techniques are sound input reduction. Of course, sometimes hyperacusis is so intense that we need also some medications to reduce the nerve sensitivity at the brain level. We have operated on people with hyperacusis to plug up the inner ear windows to reduce the sound, the sound transmission to the inner ear, and sometimes that helps some people. So that's what's available for hyperacusis. Reducing the sound, using medication to reduce the nerve excitability, and in certain candidates, surgical patching of the inner ear windows to decrease the sound pressure level.
According to the World Health Organization, the amount of people living with hearing loss will be more than people living with dementia, diabetes, and Alzheimer's combined by 2050. Are there companies working to find cures to help with this?
The question is how the incidence of hearing loss is growing so high that it is surpassing diabetes and hypertension and everything else you could think of. Because, as we get older, we're going to get hearing loss. I mean, there's no question about it. I tell people, everybody who walks into this building has some kind of hearing loss. It's very common. You don't have to have diabetes or hypertension. but hearing loss is a very common aging thing, and hearing loss is either genetically programmed, noise-induced. They did some research in some African tribes in non-industrialized world where there's no cars, there's no sound, it's quiet. And those people have less hearing loss than the city people. Although we don't think we're exposed to loud noise, we are, and we're not even aware of it. So genetics, loudness, aging, all of that is affecting our hearing level. There are lots of studies looking at how can we replace the hair cells that are dying to restate hearing. Millions of dollars are being spent on this. We do not have the secret to that yet, but it'll come. The other thing that is interesting is that the ear has become very interesting to Apple and Google and Bose and all of these mega companies that make hearing things. And now they are focusing on producing hearing devices in their own way, because they believe they're not doing it, because they're concerned about your hearing loss. They're doing it because they believe that the ear and hearing is the door to your brain and to whatever they want to sell you. So all of these companies are interested. It's not just the hearing aid companies anymore. It's all of these high-tech companies that will be coming into the market to enhance hearing for our benefit as consumers and for their benefits as well. It's their business.
I am bilaterally implanted. Why can't I always make out the words clearly when I'm streaming to my CI or in a loop setting?
So this is a person who has bilateral cochlear implants and sometimes cannot understand the words. The one predictable thing with cochlear implants is that the audiogram is going to look like wonderful hearing. The thresholds of hearing normalize with a cochlear implant. The unpredictable thing is, what is the word recognition score? What is the discrimination score? So, and that varies. Same cochlear implant, different individuals. This person goes up to 50 or 60% word recognition. Another person goes to 70, 80% word recognition. Same device, same surgeon, same everything. Why? What's the difference? The difference is the number of nerve cells that are still alive in your system that have to respond to the stimulus from the implant. The less nerve cells you have, the less you're going to understand words. And that is something that so far we cannot predict before implanting you. As I said earlier, the longer the time of non-stimulation, the worse the results with the cochlear implant. And we have tried to do some tests to see, is there a pre-implant test that can predict the outcome? And we haven't seen that yet. We know from our cognitive testing that the more cognitive decline you have, the less comprehension you have. So that's one part of it, because the brain is not able to understand and work on the information that is being sent in by the implant. So what's coming up in the next month or so? We will have another session talking about dizziness and balance and vertigo and so on. We also have another session talking about the ear length system, how it works and the results and so on. So if you're interested in that, you probably will be receiving notices about that, and I will be looking forward to talking to you again.
There's one more question.
One last question.
What can a person do to help improve their cognitive ability?
What can a person do to help improve their cognitive ability? There's a lot of things that you could read about. You need to keep your brain working. You need to keep it going, whether it's by reading or puzzles or games, or the more you stimulate your brain, the more you preserve your cognitive function. Being isolated, not talking to people is not going to do it. Playing board games, that's helpful. Doing puzzles, that's helpful. And so many different other techniques that you could Google and see what kind of brain teasing exercises you could do to keep your brain awake. So I thank you all for your attention and for joining, and I will see you again at another time.